As today, we are highlighting exceptional work that has been produced by colleagues who presented this at the conference. And the goal of this session is to highlight work that has looked at how family planning can help us improve developmental outcomes. And when we think about developmental outcomes, we are not just thinking about economic growth or GDP per capita, as most of our conversation around family planning being a catalyzer has been focused on that. We're thinking about the other developmental outcomes that family planning can help us improve, such as maternal health, such as climate change. And in today's session, what we did is we curated among all of the abstract submissions that were accepted to the conference and created a list. And that list of out of the more than 1,000 papers that were submitted to ICFP, we came up, the scientific subcommittee, with a short list of around 200 papers. And then among those 200 papers, we did a second review to identify the 11 papers that were a best fit to fit with this session. So it is a great honor for me to be here moderating this session. And I should have started by introducing myself. I'm Carolina Cardona, and I work as an assistant scientist at Johns Hopkins Bloomberg School of Public Health. And I am also wearing the hat of leading the scientific subcommittee for this conference, so which is why I'm also doing this moderation for this session. So in order for us to start and not get into more delays, I will call the speakers. And the way that the session is going to work, we're going to have them come up the stage in groups of 4. So first, we're going to have a 4 of the speakers sitting here, and they will give us a brief 4 to 5 minute presentation to show us the highlights or the key takeaways from their work. Then the 4 speakers are going to come back to the table, and then we're going to have the second and the third group. So let me please invite the first group of 4 speakers, Dr. Saifuddin Ahmed. Dr. Ahmed is a professor in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. He has published more than 190 papers in high-impact journals, such as The Lancet Global Health, and BMJ Global Health. And today he's going to be presenting his findings related to maternal health. Let's also please welcome to Delagle. Ms. Delagle is a public health and development practitioner. She holds an MBA and an MPH and an MSA supply chain postgraduate degrees from the University of North Ghana and Illinois in the United States. She is currently serving as a program specialist for sexual and reproductive health and rights at the United Population Fund's in Ghana country office. Our third speaker is Bekele Belayuhu Tefera. Thank you. Dr. Bekele is a public health researcher and data scientist, and he is the Director of Evidence and Learning at Population Services International, where he leads the monitoring and evaluation innovations, overseeing the translation of evidence into actionable rights that drive smarter decisions. And finally, our fourth speaker is Naveen Kumar Roy. Naveen is currently working as a consultant for Avenir Health in the Track 20 Project India office, and he collaborates with the Family Planning Division and the Ministry of Health and Family Welfare in New Delhi. So please, let's give a big round of applause to our 4 first speakers.
Otherwise, I can look into it. That's fine. Okay, that's fine. Where is that? Oh, here? This one? This back? Okay, thank you so much. Hello, everyone. Thank you so much for coming to the session and attending. We truly appreciate your presence here. When CDC, US CDC, Centers for Disease Controls, looked at all the development factors that really improve the health in the United States, CDC found that and identified family planning is one of the top 10 most best health investment they made to improve the health in the United States. Now, family planning has been all the time being presented as a population control issue. But again, this is not a population issue at all. This is women issue, women's health issue, and this is absolutely, I really consider family planning as a sort of like a vaccination for women, preventing their death, improving their health, and also preventing the child mortality. So we just published a paper in the Lancet Global Health, and I have given a copy in your table, and that's essentially looked at the effect of the maternity care, improvement, fertility decline, and contraceptive use on global maternal mortality education, maternal mortality reduction. And that paper really came out on November 3rd. And primarily the finding of the paper, I want to make it very highlight the finding. And that really study shows that the very first thing we done in 2012 at the launch of AP23 or the family planning program that was launched in the UK. In that one, we really shown this paper in 2012 in the Lancet that the maternal mortality was reduced by the contraceptive use almost like a 44%. And if we can really additionally meet the unmet need, that will reduce additional 29% of the maternal death. As a follow-up of that study, the new study has essentially shown, we try to examine the effect of maternal mortality reduction between the 2000 and 2023. So over the 23-year period, what is the contribution of the family planning and fertility reduction compared to the maternity care? And some of you may know, when the Safe Motherhood Program was launched in 1987, family planning was recognized as one of the pillars, or one of the 4 pillars of the Safe Motherhood Program. And what we really find, this paper essentially has shown that the mortality reduction, almost like a 40% reduction, maternal mortality reduction has occurred between 2000 and 2023. Of that 40% maternal mortality reduction, 61.2% of the maternal mortality reduction was due to maternity care improvement. And 38, almost like a 39% was due to the fertility reduction. Just think about it. And think about the cost issue. Okay, how much you really invested in reducing one maternity death through the contraceptive use and through the maternity care. And we also had additionally examined and found that just by increase of the contraceptive prevalence during this period of time, also essentially some sort of like reduced like a 77,000 maternal death. If anybody is familiar, in 2023, the number of maternal death was 260,000. So instead of the 260,000, additional 77,000 deaths would occur if the contraceptive would remain at the same level. Just think about it. And this has shown, if you look at this column and this column, this is shown the maternity effect, and this is shown the contraceptive, the fertility reduction effect. And you can see that many regions, even in the top line is showing the world and other regions, you can see the most of the regions, particularly the sub-Saharan Africa, Latin American countries, extensively benefited from the improvement in the contraceptive use. Okay. The next slide I will show you is essentially show anybody working in the family planning also must recognize that how much inequity has been reduced and how much improvement has occurred also in the poor families, in the poor women, in improving the contraceptive use. So this was done by the next generation and outstanding scientists. I asked her before the meeting that, are you going to present this result? She said no. And she was responsible for selecting all the papers that were presented. So I said, okay, fine. If you don't present, I will present it, considering that the importance of this paper in addressing the inequity issue, which is critically important. Everybody should know how the family planning program has improved access to the contraceptive method to the poor women and the poorest of the poor women. And this was done by Carolina. Okay? So this is the paper. I really, really want anybody interested in family planning, anybody working on the family planning must read this paper. This is critically important. You must know this paper. And if you look at it, this paper has shown all the inequity that has been reduced based on the last 20 years, almost like the last 20 years. So I will stop there. Thank you.
Thank you, Saifuddin. Very flattered to see that on your presentation. Much grateful. Now let's go into our second speaker, please, Dr. Delagle.
All right. So the second presentation is on, it's on investing better, more and better in family planning. And we are saying that investing in family planning, putting money in family planning is not a cost at all. It is an investment, a smart investment anyone can make because it unlocks a lot of economic benefits. It promotes gender equality, promotes education. So we need to rethink family planning investment, not to be seen just as a health intervention priority or as a cost. So the goal of the investment case we presented was just to make a compelling argument showing the health and economic benefits of scaling up investments in family planning in Ghana. Oops. All right, so what was the theory of change? So we're saying that we really need to achieve certain national and international targets we had set for family planning, maternal health, etc., for Ghana. But to do that, we had to do a projection of how much we would need to invest in family planning and maternal health services between 2023 to 2030 to be able to attain the targets we've set for ourselves. And for those projections to happen or to become realities, we needed to make some investments. So what were those investments that were needed? So we needed more money to be invested in a very smart manner, to be able to scale up interventions. And then from scaling up in the interventions, we were reaping a lot of health outcomes. But beyond those health outcomes, which most of us are very familiar with, are economic benefits that we can unlock. So we came up with 3 projection scenarios. One is business as usual, looking at our historical trend of family planning, improvements, and unmet need reduction over the years. And we said that if we continued business as usual the way we've been doing historically, then we're not going to achieve the targets that we've set for ourselves in our national targets, in our FP 2030 targets. So if you look on the slide, baseline, we are 28% per demographic and health survey for MCPR. I think we all in this room know what MCPR is. But then if we continued with the business as usual scenario, we're only going to hit 31% by 2030. And that is not the target that Ghana has set for itself. So we move to another scenario, which is an achievable one. That achievable scenario looks at the target that we have set, which is moving MCPR from the current 28 to 44.4% by 2030. And then we looked at another scenario, which we call the ambitious scenario. So with that one, we're saying that let's try as a nation to invest to make sure that we even move past the national targets and be able to meet all the unmet need plus our current MCPR. So we're looking at a total FP demand, which takes us to almost 60%. But then to achieve these 3 scenarios, what are the interventions that are required? So for the business as usual scenario, when we use the tools, the modeling tools that we used, we said we would need about $48 million between now and 2030 to be able to achieve the business as usual, not too good MCPR of just like 31%. So we needed more money, which is like 99 million, to scale up, to be able to achieve our targets in our ICPD documents, in our FP 2030 commitments. But to move beyond that, to actually gain our ambitious target of making sure that we meet all our unmet need of about 23%, then we needed a whooping 163 million. But then we shouldn't look at these investments as cost because there are a lot of benefits that come out of it. So for the health benefits, which most of us are familiar with, we said that if we continued in the business as usual scenario, unintended pregnancies that will be averted were around 4 million. Maternal deaths about 8,000 plus, and safe abortions averted about 1 million plus. But then if we move to the achievable scenario, then you see that we are doing about 50% more, averting unintended pregnancies to around 6 million, maternal deaths 10,000 plus, and safe abortions averted 1.9, almost 2 million. And then the ambitious scenario gives us even better results. So unintended pregnancies averted were over 7 million, maternal deaths averted over 13,000, and unsafe abortions 2 million plus. So if we translate these into economic benefits using the modeling tools, we are saying that for the investment of just the 48 million that I alluded to earlier, the economic benefits are 127 million USD. So 48 to 127. If we do our math right, 48 times 3 gives us 120 thereabout. So we are reaping 3 times more what we invest into family planning. Now, if we look at the achievable scenario, we needed an investment of about 48, no, I can't remember. But when you look at the investment, because I don't want to go back, we reap over 4 times more what would have invested. And then with the ambitious scenario, the reap over that is even higher. So when we translate that to how much investment we make out of every dollar, that's the other bar graph there. So out of every $1 invested for business as usual scenario, we get 2.6 back in returns. And then the achievable model, for every $1 that we invest, our return is 4.3. And then for ambitious, every $1 invested, the returns is even higher, almost $7. So what are the key messages that we are saying from this? This is a very summarized PowerPoint from what we had earlier. So we are saying that investment in family planning service can reach thousands of new modern method users. It can avert several unintended pregnancies. It can avert several maternal deaths. It can avert several unsafe abortions. And when we translate this into economic terms, then we know that it's going to improve, like the earlier speaker alluded to, the economic well-being of women, of families, of the countries at large. Because we know that if that girl goes to school and finishes, completes, contributes meaningfully to the labor force, the returns on that to the labor market, to productivity, to the development of the nation is simply unimaginable. And then put together, we are saying that for every dollar invested, the economic returns ranges from between $2.6 to almost $7. So long-term sustainable funding and financing from domestic resources is possible. Yesterday, when we were doing the oral presentation, we showed how we can harness domestic resources to make these finances or to make these investments. It's not always looking out at the traditional sources of development partners and of donors. We are looking within, public efficiency, making sure that budgets that are allocated are released, and when they are released, they are used for the purpose for which they are released, and that accountability mechanism is in place to make sure that there's efficiency and leakages are kind of sealed up, and then we are able to harness monies back into family planning services. So I guess this is thank you very much.
Thank you very much, Della. Our third speaker is Dr. Bekele Balayun. Do you want to? This presentation is going to be focused on agency, from access to contraception, and how that can translate into increases in agency.
Thank you. Thank you all for your patience. After all this distraction of our time, we spend a lot of time to sit here. And my presentation, I had a presentation in the last 2 days, which was focused on how the Ethiopian government expand adolescent family planning service using smart start approaches. And my presentation current specifically focusing the power of family planning, not from access to agencies, because I have already shared all the experience what we have in access for agencies. But specifically, I want to speak in front of you now is the importance of investing in family planning for lasting impacts. How Smart Start is a government-led initiative, it's impactful and efficient to ensure the accessibility of family planning service in marginalized adolescent girls. So how supporting this adolescent to make informed and confident for the decision of their future. So Smart Starts, actually, it's a government-led initiative supported by Gates Foundation financially and technically supported by PSI Ethiopia. It's a demand creation with quality service activities aimed to improving impact and ensuring the sustainability using the existing health system approaches. So the approach, the initiative use client-centered counseling approach which helps to adolescent connect with family planning, with the financial and life goals of adolescent health. Actually, I am presenting here is not a research finding. It is a practical implementation, how we are going to translate evidence into practical actions. So this financial planning is an entry point when we are talking about family planning, to ensure that approaches are transforming family planning discussion into meaningful conversation that about aspiration, finance, and the future of adolescent health in a meaningful ways. So the approach is, it's a phased-based approach. It's a phased-based approach which allow, Smart Start to expand meaningfully and progressively with expected maintaining service qualities. And this phased-based approach, the approach is bringing a new lesson for us that refine and strengthen the implementation approaches. So this scale-up approach is not one-time activities. It is, ongoing process driven by or led by, guided by evidences. So specifically, I want to focus on the research goal, all the initiative, all the process we generated multiple evidences using the existing data sources. What we have is HMIs, and as well as to clearly understand the client perspective and how we are providing and maintaining the service and ensuring the sustainability, as well as ensuring the satisfaction of the clients and also the fidelity during the implementation. So these things are specifically how we are assessing and measuring the impact of the services. So the key findings of this implementation, more than, 500,000 of adolescent girls are accepting new family planning as the first times. So this Smart Start initiative expanding the service, the side productivities are increasing by 60% of the service that can be providing. It's not an impact, it's beyond the impacts. It is a signal for ensuring efficiency. Over 95% of the facilities are meeting the quality standard. That can be, offering respectful and informed care for every adolescent adolescent girls who need a service. So counseling qualities are significantly improved from 68 to, 86. This ensures that adolescents are not only getting a service, they also, truly understand what options they have and what methods they want to take. So when we are looking about the spillover effect, family planning use are increased by 45% in the intervention areas compared to non-intervention areas. So these approaches, it is a signal how integrated approaches, specifically strong technical support in the system, it's improving the quality and the strength of the service, especially growing. That will be helpful to empowering more people and more communities as well as, their futures. So why it matters specifically in a smart start? It's integration. We started with the most marginalized groups. It's the first mother, 15 to 19 age groups. You can imagine how much they are marginalized. 70% of adolescent girls are married before the age of 17. 82% of adolescent pregnancies are being unintended. You can imagine, adolescent health are stigmatized and how we are improving. So this, help us to deliver strong result and ensure the trust into the community, as well as creating an open door to scaling up widely. So scaling is not just what I said. It's not, it's a number. It's not reaching number of girls. It's beyond that. It is last change of the system. You can imagine specifically for the girls who are facing system and social impacts. So government lead initiative and PSI technical support initiatives made Smart Start adaptable, scalable, sustainable, and responsive to the local needs. Then the last slide, what I have is call for actions. One, invest for impact. So invest in large-scale sustainable family planning solution through public system and use evidence to guide decision for the health of adolescents. Second, strengthen system for scale. Strengthen system for scale. So shifting from direct investment or direct delivery of the project to system strengthen. That helps to ensure partnership across different sectors, use data to make health systems are strong and resilient. Third, balance reach and depth. Adopt simple and scalable approaches that help to reach more adolescent girls while using evidence to prioritize their meaningful need for those specifically who are facing, social and system barriers. So before closing my presentation, I would like to say thank you, all the contributors, including the Ministry of Health, the government of Ethiopia, and partners who are supporting us, including donors, and also program teams and data collector who are supporting, to be more meaningful. And thank you to all.
Okay, I think this is working. Thank you, Dr. Bekele. I'm going to kindly ask you to please, we try to stay within the 5 minutes because we started the session late and we want to make sure that everyone gets to give a chance to give their presentation. Our next speaker is Naveen Kumar Roy.
Yeah.
So, floor is yours.
Thank you. Good afternoon, everyone. My topic is patriarchy and reproductive choices, understanding women sex preference for child in India, insights from the National Family Planning Health Survey, round 5th. Though India has achieved replacement level of total TFR in 2021, but sex preference remains deeply entrenched in Indian society, deeply driven by cultural norms that prioritize male heirs for lineage continuity, property inheritance, and old age support, while daughters are viewed as an economic burden due to uh, dowry practices and patriarchal marriage system. The consequences are severe, including gender-based sex selection, skewed sex ratio, and reinforcement of discriminatory gender norms. The primary significance of this research is destruction of sex preference as a consequence of factors like economic dependency and patriarchy rather than uh, individual choices. The objective is for this study is examine factors that influence women sex preference, child sex preference, that impact on their gender equity in India. It also investigate how cultural, economic, and local factors contribute male offspring preferences that affecting child sex ratio and gender-based practices across region. Basically, I used National Family Planning Health Survey round fifth data. It is the world largest demographic survey covering 637,000 households and 724,000 women nationally. Sorry. For this research, we used basically a bivariate analysis with chi-square test to examine association between the key covariates like a place of residence, education, wealth index, religion, etc., with the son preference. Another multinomial logistic regression also applied to examine to compute the relative risk ratio, quantifying how each factor contributing if other factors are constant. Now, the figure one shows the percentage of women who wanted more sons than daughter. Nationally, it is 15%, but if you see across region, bigger states like Uttar Pradesh, Bihar, Jharkhand, having more child preference than others. Similarly, several northeastern states like Mizoram, Arunachal Pradesh, Manipur, having more son preference than others, it is basically uh, uh, above than the national average. Second figure shows percentage who wanted at least one son in the family. You can see the result nationally, it is 18%, but the same set of states like UP, Bihar, Jharkhand, Mizoram, Manipur having reported more at least one son in their family. It is big challenge for us ki how to mitigate this issue of sex preference because it is directly or indirectly reflect on our TFR. Although we have already received, I have already explained, but some regional northeastern or central state existing this phenomena ki if a family having more sons, then more hand and more income. There is a the local ideology. Now, the result shows son preference are more prominent in rural areas, poorest household, and Muslim community. Regional differences are evident. I already explained. Central and eastern states have more higher son preference than the southern and western states. Multinomial regression revealed that son preference has increased by 11% in rural areas than that of urban area. Higher economic status means richer or richest category correlates with the lower preference of son. Age and education were inversely related to the son preference, with older and more educated women showing lower preference for son. Marital status affects son preference with married and divorced women showing 25 and 14% increases respectively compared to the never married person. Now, conclusion or discussion part, female headed household exhibit 6.5% higher son preference that challenges our traditional norms and beliefs, meriting further qualitative investigation. The impact of education and media exposure demonstrating these elements decrease son preference by 4 to 15%, providing policymakers with tangible evidence of effective intervention strategies. Third finding shows significant regional patterns. The central India exhibited 54% higher relative risk of sun preference than northern areas, even after accounting individual factors. These findings question uniform national strategies and emphasize the needs for region-specific policy measures. The crux at the, you can say, last but not the least, findings have immediate policy implication for India's gender gender equality initiatives suggested necessary actions for improved access to education, basically women education, media literacy for awareness and behavioral change, region-specific initiatives to change social norms like dowry system, eradication of dowry system, addressing paritical inheritance system. Thank you.
Please let's give them a round of applause, and we're going to welcome our second group of panelists. And again, I'm going to please ask you to try to do your presentation within the 5-minute limit, because we need to leave the room at 1:20 at the latest.
Thank you.
Can we please welcome to Dr. Mozam Ali? He currently serves as the epidemiologist and medical officer at the World Health Organization, where he provides leadership in clinical and implementation research. He is a well-published author, and Dr. Ali has made critical contributions to WHO guidelines shaping global policies to improve reproductive health care. Can we please also welcome to Angela Nalunga? Angela currently serves as the advocacy coordinator at Population Services International Uganda, where she coordinates the platform's advocacy efforts geared toward policy development, improvements, and implementation. Now, please let's welcome Bapan Viswas. He's currently working on how sustainable development goals can be achieved through family planning, and he's passionate about the interdisciplinary research, and his work spans family planning, livelihoods, poverty, and migration. And our 8th speaker is Ludy del Rosa Rodas López. Ella es una ginecóloga y obstetra con experiencia en salud pública e implementación de programas de salud reproductiva. Actualmente trabaja como gerente regional de programas en Villa Health de Population Services International. Can we please put up the presentation? Thank you. Hello? Yes, we really need to do this in 4 minutes per speaker, please, and then we will go to the next. Okay. But I really ask the president within the limit.
Thank you. Good afternoon. Thank you very much for this opportunity. What I'm going to present is results of a series of systematic reviews that we did to look at the impact of family planning and contraception on women's health and its socio-economic status. It's not working, or maybe. Yeah, this is fine. So basically, this is just to give an overview of the reproductive health challenges globally. looking at very high maternal mortality, child marriages, unmet need in family planning, induced abortion, very high STIs, and intimate partner violence. So these are broader reproductive health issues globally that I just wanted to highlight. Uh, when we talk about the impact of or the usefulness of contraception, we are normally talking to the converted. We do not talk to those people who do not have the health background, or we are not able to convince people who are the policymaker without any health times. So the main purpose of the systematic review was to generate solid evidence-based science related issues, evidence-based science, so that we can talk to the policy makers based on the actual evidence that is present in the context of contraceptive use and its impact on women health. So these were some of the questions that we were looking at. How does contraceptive use improve reproductive health outcomes, non-reproductive health outcomes, and whether there is any association between contraceptive use and women empowerment? This is, I'll show you. First of all, we looked at the maternal mortality and morbidity. That is a very important component. Does family planning or contraceptive use has an impact on morbidity and mortality of the women? So we looked at different studies, and as I think most of you are familiar, one of the very strongest study was done in Matlab in Bangladesh, where they followed up the women who are using contraception versus control who are not using, showing very increase in maternal mortality among the control compared to those who are using contraception. So there were other studies that also highlighted the same, that there is definitely a link between use of contraception, and it mainly occurs by preventing against preeclampsia or high-risk pregnancies and birth. We were also very interested in whether contraceptive use also improves the women empowerment. So we used this framework developed by Kabir and then refined by Parata in 2017. We looked at sources, agencies, and achievements. So that was the framework under which we looked at how contraceptive use can be linked to women empowerment and agency. Now, this is very important to note that we have not included any qualitative study in this one. Majority are RCTs, majority are cohort studies or case control studies. We overall, in all the 6 systematic reviews that we have done, there were approximately 180 studies that we were able to find. And these results that I'm showing you are basically based on the clinical trials, on the cohort studies. So we were able to find 16 studies that actually showed a strong linkage between contraceptive use and women empowerment, whether it be in terms of wages, education, decision-making, or her own well-being and the well-being of her child. We also wanted to look at these 3 components, whether there is any linkage between contraception, cancer, mental health, and menstrual health. So these were noted that contraceptive use definitely leads to decrease in ovarian cancer, endometrial cancer, and few other gynecological cancers. We also noted that there was certain slight increase in cervical cancer, but it is after a prolonged period of time of use of certain methods, not for every method. And we have the opportunity of using cervical screening and HPV vaccine. This is about whether contraception use has any relationship with mental health. We were able to demonstrate that there is definitely a link where it decreases depressive symptoms among women with pre-existing mental disorders, and there is also some protective effect on anxiety among women. We also looked at menstrual health. The study shows that there is definitely a symptom of abnormal bleeding, endometriosis, uterine fibroid, and dysmenorrhea, and also pain associated with endometriosis increases due to use of contraception. And also, it was also shown that the leiomyoma size can also be decreased by the use of contraception. So there are a number of benefits associated with contraception for women health. Definitely, there are approximately 874 million women who are currently using contraceptive method. There are definitely health benefits. There are socioeconomic impact and benefits associated, whether it is in terms of the things that I've shown or in terms of education, employment, and other opportunities that lead to better agency, empowerment in decision-making, and for better use of resources to better take care of themselves and their families. So I end here. This is the QR code for the document that WHO has briefed of all these six systematic reviews for easy access. And happy to talk to colleagues in case they need more information. Thank you very much.
Thank you very much for that presentation. Let's go into the next, please, Angela.
Okay, as the IT team comes on, I'm Angela. I work with Population Services International. And I'm happy to have some of my colleagues here and one of the co-authors, Precious Mutoru, as well as the Minister of Health in the Department of Health Promotion around here with me this afternoon. I'm presenting on the accreditation of pharmacies as a new channel to administer injectable contraceptives in Uganda through the DISC project. DISC is delivering innovations through self-care, and it's funded by the Children's Investment Fund Foundation, as well as the Gates Foundation. It really aims to support mothers and young women take control of their sexual and reproductive health needs, especially through creating demand and access to injectable contraceptives. And we work through the Ministry of Health and other local authorities to ensure that this is a success. For this particular presentation, I'm presenting for a new policy shift that happened in Uganda, where pharmacies have now been approved to provide injectable contraceptives within the setting in a bid to expand the private sector to reach our total market approach. Just to take a quick snapshot about the DMPSC scale-up and the market share for family planning within Uganda. So the national scale-up of family planning, especially for the provision of injectable contraceptives, started through 2020 with an approval to have these methods administered within the drug shops. After intensive implementation by the different partners, 2 years down the road, it compelled stakeholders to think of other channels that we could expand to, and the pharmacies were really one of the first channels to have these implemented. Over 50% of Ugandans access their family planning through the private sector. And out of those, 23% of the women use the private sector to obtain their family planning contraceptive method. The injectable contraceptives are primarily sourced through the private sector in Uganda, with 54%, then 36% through the public sector, which really needed an opportunity to grow the private sector to have these contraceptives therein. The impact so far, this approval has come through now a year, because we had it in October 2024 by the National Drug Authority. This is just a quick snapshot of the 1 year of implementation since the approval began. It already set the introduction and scale up of DMPSC through the private sector, especially the pharmacies. In Uganda, we have now a DMPSC private sector commodity, and it's available through the different pharmacies. So far, we have 22 pharmacies that have been accredited to provide these injectable contraceptives, and 15 have conditional approval, but we continue to monitor. Then, of course, we've gone to set the pace for the integration of other health areas within the private sector, especially the pharmacies, including vaccination. We've seen a cost reduction to ensure that all costs are minimized. We've seen a cost reduction from the initial cost of importation having a sale at 14,500 Ugandan shillings to 7,500 Ugandan shillings. And then we've also seen integrated quality of care frameworks adopted. For example, the support supervision tools that are being developed and are being used by the Ministry of Health and the private sector. Then also strengthening reporting and data management system through the private sector to ensure that it is within the national reporting database, HMIS. What we are looking forward to do or looking ahead, we look at strengthening documentation. With strengthening documentation, it will support in documenting any side effects, any reactions, the pharmacy sales and the private sector, so that we have it rolled out beyond the 22 that are currently accredited to other pharmacies to take it on. Then, of course, institutionalization of the reporting systems to ensure that the private sector data as well is contributing to the national modern contraceptive use, prevalence rate, and also reducing the maternal mortality in that case. Then also approval and structured scale up through the digital channels is one of the avenues we would like to explore, especially with availability of funding. Yeah, thank you. I would stop at that. Those are the co-authors. You could scan here to talk further. Thank you.
Thank you very much, Angela, and thank you for staying within the limit. Now we're going to hear from Dr. Bapam Bispas.
Good afternoon, everyone. I am Bapan from India. So this is a field research work that deals with how family planning impacting to gain the sustainable development goals in India. So this is the conceptual framework of my field-based research work, which deals with how gender and demographic dimensions, along with reproductive health and socioeconomic factors, are impacting family planning, and how family planning is linked with different sustainable development goals. This is the secondary database outcome that shows that in India, when it comes to the avoid pregnancy, the modern method, female sterilization is the main method that Indian women are using. That is around 37.83%, followed by pill and condoms. When it comes to the traditional method, these are rhythm method and withdrawal. But in the case of male sterilization, it is very less, that is less than 1%. When it comes to the knowledge of having any kind of family planning, yes, India is growing faster and India is doing great. However, there are some spatial disparities in India regarding the knowledge of family planning. This is the outcome from a primary survey which shows that, in that case, I have surveyed around 384 households where 69% of households are having access or following family planning. However, knowledge is compared to higher, that is 77.6%, and most of the deliveries are institution deliveries. And majority of them are using modern current method of using contraceptives is modern methods. Now, the outcome is that from the statistical models and statistics, the binary logistic regressions I have applied, and from that outcome, it is clear that the female-led household is more likely to adopt family planning methods, because in that cases, female are more you can say enjoy to decide whether they will use of contraceptives or not. So it is impacting positively on gender equality. At the same time, those who are following family plannings, they are attending ANC attendance along with and also prefer institution deliveries. That leads to less maternal death as well as child death. So in that case, it also link with good health and well-being. At the same time, those who are having small families, the gap between two childs is high, are having the facility to invest more in their education, their child health. So in that case, we know that in malnutrition poverty, health is a major dimension. In that case, family planning also positively playing a great role to achieve the non-poverty status. At the same time, there are certain cultural groups and religious groups in India having higher fertility rate. So in that case, to bridge that discrimination, family planning can also point that can achieve the goal. At the same time, there is a gap between rural and urban areas. Rural who are coming from urban areas are having higher access the contraceptives or model family planning compared to rural areas. But over the time, I can say that in India now the total fertility rate is 1.9, and it varies 2.8 to 1.2 in different states. So India is doing great over the time. At the same time, there is a slogan in our country that is "Hum do Amar do." It's a Hindi slogan that in English translated it is "We will have to." At the same time, ASHA that are doing great in the ground level, as well as government authorities are providing free contraceptive pills and modern contraceptive methods like condoms over in different PEHC, that means public healthcare facilities sectors. So India is doing it over the time, and it is a cost-effective method of to achieve the sustainable development goal using or following the family planning. Thank you so much. Thank you so much.
Thank you. And our next speaker is Ludi del Rosario Rodas.
Hola, buena tarde, muy amables. Voy a presentarle la experiencia de 11 años de trabajo en Guatemala, en hospitales de Guatemala y Honduras. Tenemos un año de trabajo, así que voy a concentrarme en los resultados y la estrategia en Guatemala. Básicamente buscábamos con la estrategia fortalecer y desarrollar competencias en los médicos de 11 hospitales dentro del Servicio de Salud de Guatemala para mejorar la calidad de los servicios de atención posaborto, que impactara además en la mejora de la calidad a acceso a métodos de planificación familiar. Históricamente, las mujeres que iban a ser atendidas por atención posaborto podían pasar largas horas en una camilla esperando ser atendidas para un legrado instrumental, y así que la estrategia buscaba mejorar la calidad del servicio. ¿Qué intervenciones hicimos? Básicamente necesitábamos tener y trabajar de la mano con los ministerios de salud y algunas organizaciones aliadas que pudieran fortalecer los procesos continuos de atención en los servicios. Priorizar la intervención dentro de los planes nacionales era clave para que la estrategia fuera sostenible a lo largo de los años. Generar las competencias y las habilidades en todos los médicos que rotaban en los servicios de atención posaborto para no tener un quiebre en la atención y que la misma se mantuviera durante las 24 horas, los 365 días del año en los servicios. Dentro de los procesos pasamos por un proceso de hablar y concientizar sobre el marco legal relacionado, nacional e internacional, sensibilización sobre valores, básicamente para que pudieran apropiarse de la estrategia y no solo tener las competencias y las herramientas, sino que dar un servicio de calidad. Siguiendo, teníamos un proceso de supervisión periódica habilitante que favorece la mejora constante y el compromiso constante de los proveedores de salud. La formación de equipos dentro de los hospitales para un compromiso más propio y que ellos mismos fueran buscando la calidad y la mejora constante. El acompañamiento continuo desde nuestro lado para poder fortalecer esos lazos, responder sobre inquietudes y mejoras del sistema. Y una formación actualmente de entrenadores que pueda sostener la capacitación, tomando en cuenta que en nuestros países la rotación de los proveedores sigue siendo alta dentro del sistema de salud. ¿Qué resultados tenemos? Después de 11 años de intervención, para ponerles en contexto, el aborto era la cuarta causa de muerte materna por más de 2 décadas en nuestro país, y actualmente, luego de 11 años de intervención junto con otras organizaciones aliadas, ha bajado de un 6 a un 3%, saliendo, y ya no es la cuarta causa de muerte, ya no alimenta la muerte materna en grandes proporciones. Así que lo que estamos buscando actualmente es la sostenibilidad de los procesos, buscando que de estos 11 hospitales sean centros de referencia para otros hospitales que puedan mantener la calidad de los servicios y que puedan ser centros de pasantía para otros hospitales que adopten las estrategias. Finalmente, ¿qué aprendemos? y queremos compartir es que la capacitación constante de los proveedores de salud no se termina, tiene que ser actualizada constantemente, que los protocolos tienen que ser claros y tienen que estar establecidos desde el ámbito nacional para que los proveedores puedan ejercer con confianza y basados en la evidencia los servicios que prestan, un compromiso institucional e interinstitucional con un liderazgo activo desde los líderes que tienen que soportar las estrategias y financiamiento de los programas y mantener la ampliación de los accesos a los servicios de planificación familiar para que ninguna mujer pueda salir de los servicios sin tener la oportunidad de haber recibido la información clara y digna sobre la planificación familiar y adoptar un método anticonceptivo. Así que en aras del tiempo, gracias por la oportunidad.
Thank you. We are not going to be able to put up the presentation of the next three speakers, but I am going to ask them to join up here, and I am going to introduce them and just the title of their work, because we do need to leave the room because we have the opening ceremony next. So please, I am going to introduce first Aisha Bello, who was not able to come here, but she has her colleague Natalie representing. But just to emphasize that Aisha is the program coordinator for the Married Adolescent Safe Spaces at the Center for Girls Education in Northern Nigeria, and that her work was focusing on reproductive autonomy as a tool for economic empowerment. I am just introducing her in the stage so that in case that you want to have a conversation after, you are able to do that, please. The next winner for this award was Janatul Munia, who was going to present, she currently serves as the knowledge management expert at the ShareNet Bangladesh, hosted by Red Orange Communications, which is one of the largest knowledge sharing platforms in Bangladesh for sexual and reproductive health. And then our last awardee was Mayank Singh, who is an assistant professor in the Department of Epidemiology and Biostatistics in Karnataka, India. So apologies that we are not able to listen to their presentations, but we do have to leave the room. And I'm going to ask the other awardees from the first panel, please, to come up the stage so that we can give them all a big applause. And we've also prepared a few gifts for our FP awardees. So if someone can help me bring those things in the table, that would be great.